Thank you, Ida. Thanks a lot for the introduction. And yeah, it was a really long journey. And finally, in Bentiu, last year, after 19 years after Mornay and 12 years after the vaccination, the vaccine was licensed, we were able to vaccinate the first people, the first woman. So we did that in Bentiu IDP camp in South Sudan, in a big camp of 120,000, a camp that suffered from recurrent flooding and poor access to water and sanitation. In this dense, hard-to-reach area that we vaccinated all people aged between 16 and 40 years. So almost 27,000 people for 3 rounds from March, April, and October 2022. This one. Yeah. No? I didn't. What I did wrong? Okay. This one. So concurrently with this widespread vaccination effort, we conducted operational research. First, we aimed to describe and understand the population adherence to the vaccination campaign. Second, this vaccine is a recombinant vaccine that is known not to present any risk to pregnant women, which is why they were included in the campaign. However, this is a new vaccine. We sought to document its safety in pregnant women. And including pregnant women is crucial for 2 main reasons. First, they are at high risk of hepatitis E, as explained. But second, if you exclude them without test, actually, you have to exclude all women of childbearing age. And finally, lastly, the vaccine demonstrated significant efficacy in a clinical trial conducted in China, where efficacy was assessed after 3 doses. Estimating efficacy after 2 doses proved challenging to limited number of infections. Hence, we sought to evaluate its efficacy of the vaccine in the South Sudanese context, particularly in a response to an epidemic following administration of 2 doses. So I will now try to briefly show you the main results. Yeah. So the first question on coverage, we found a high coverage of at least 1 dose of E. coli vaccine after 3 rounds of vaccination, and no case of severe adverse event following immunization. We found no significant difference in coverage of at least 1 dose by age group or between pregnant or non-pregnant women. On acceptance, the 8 focus group discussion of 6 to 8 participants shows that participants were familiar with the disease, having experienced it directly or indirectly. The disease was perceived as serious among pregnant women, also among children and the elderly. The discussion revealed a high level of acceptability of the vaccine and confidence in those who provided it. The main barrier was the temporary absence during the campaign, and there is a demand for the vaccine to be made available for the children and people living outside the camp. So, on vaccine safety on pregnancy, we sought to answer 2 causal questions. First, to determine whether vaccination against hepatitis E during pregnancy increased the risk of fetal loss, and second, if vaccination before conception increased the risk of fetal loss. To do this, we conducted a cohort study to compare pregnancy outcome in vaccinated and unvaccinated pregnant women. An exhaustive census in this big camp of 120,000 people of all pregnancy was carried out in Bentiu camp after the second vaccination campaign, and women were revisited 28 days after the expected delivery date to document pregnancy outcome. To help overcome the potential biases associated with observational study, we used an emulated target trial framework in which the protocol of the ideal clinical trial that should have been conducted is specified and then emulated with observational data. So the relative risk of fetal loss between women vaccinated during pregnancy and unvaccinated women was 1.1 with a confidence interval of 0.7 to 1.8. Similarly, the relative risk was 1 between women vaccinated up to 90 days before conception and unvaccinated women. The bias indicator, I will explain after a bit what does mean a bias indicator, show a higher but non-significant risk in vaccinated women, suggesting that there was no bias, or if there was a bias, it exaggerated artificially the risk in vaccinated women. In addition, we performed several sensitivity analyses by modifying the matching criteria, reducing the number of variables, including propensity score for matching, selecting some sample. For example, we excluded all women who reported vaccination only orally without card to prove it. And all these sensitivity analyses show similar results. So no evidence of increased risk in fetal loss. Sorry, I didn't show you the second. So the first was for vaccinated during pregnancy and the second before conception. To assess the effectiveness of the campaign in the field, we strengthened surveillance by seeking to detect and test all cases and by improving laboratory tests to certify cases. We carried out a case control study in which we recruited cases eligible for vaccination detected by the enhanced surveillance, so at the facility, and matched them with up to 6 controls according to age, sex, and place of residence, and this control found in the community. The case control study can be potentially biased because individuals seeking care at facility may differ from control in the community. To estimate this bias, we use a bias indicator, so we measure the effect of the vaccine in individuals exhibiting symptoms but testing negative for hepatitis E. And if not bias, this effect should be null. So to control this bias, we also use a test negative design comparing vaccination odds in HIV positive and HIV negative case. So that's the second test negative that we did. So in our primary analysis with community match control, we estimated a non-adjusted effectiveness of 2 doses of vaccine of 67.8% and 55.3% after adjusting for potential confounder. In our bias indicator analysis, we found those seeking care for non-hepatitis E acute jaundice were more likely to be vaccinated than their match control in the community, suggesting the risk of potential negative bias. The test negative design, which control for health-seeking behavior, estimated, as expected, that the unadjusted vaccine effectiveness was 80%, and after adjustment for potential confounder, 88.3%. In conclusion, we did reach the population. They did accept it. We had a high coverage, a good acceptance, and a demand from the population, even beyond the population we targeted. We didn't find any evidence suggesting any risk in vaccinating pregnant women. And despite the small number of cases, reduced dose regimen, 2 doses, appear to have been effective in reducing disease in this highly exposed population. Sorry. So I want to thank the Ministry of Health of South Sudan, which was a great partner. WHO was really helped us during all this journey. I want to thank all MSF staff who participate to this all this observational study, quite a lot. Thanks also the community of Bentiu. And a big thank to Robin Nesbitt, the principal investigator, who couldn't be here. Alors, je le dis en français, qui peut malheureusement pas être là aujourd'hui.
Unfortunately, he cannot be with us today.
Et c'était Robin qui a mené la plupart de ces études.
And Robin carried out most of these studies. He was the main investigators, and I'd like to thank again Isa and Andrew. It's been a long fight, and I'm really proud to tell you today that we were able to vaccinate and measure the outcomes in that population.